Thanks a lot, Dr. Trong. That is a great lecture, and I think that one of the interesting things is how bone biopsy and the results are so variant. And one of the things that we talk about, I think, frequently in our facility is not only how variable the results. We typically tend to let's say refuse to do bone biopsies when it comes to the toes. The reason that we do that is because, generally speaking, when you're using a Jamshidi needle and you try to take a bone biopsy of these small areas, you basically destroy the integrity of the bone. It's very difficult to get, and you might as well just do an amputation at that point. Well, maybe not an amputation, but a phalangoectomy maybe. And
Rose, we are having internet issues here. Rose, can you hear me?
I was always curious, what these do. I have Dr. Joseph. Are you doing bone biopsies every time? I can hear you just fine. Go ahead if you have a question, please. I'll see if I can find a better connection spot.
Yeah, I didn't hear the end of your comment, Dr. Lamari, but I agree with you. Like, depending on where the site of infection is in the distal phalanx of the toe, it's definitely a very difficult location to get a biopsy because those bones are so frequently so small. When you're on most like 11 gauge Jamshidi needle going in, you pretty much just take away 80% of the bone. So in those areas, definitely is not really amenable to a biopsy. But like the more proximal area of the foot, the midfoot, the calc, ribbon tibia, definitely those are more amenable to a biopsy.
But if everyone can I say something, I was just gonna let everyone know in the audience, as I mentioned earlier, we have over 450 folks are watching this. Dr. Lamar's electricity went out today. So she's in 100-degree temperature. I hope you don't mind me sharing, but you're such a trooper. I want everybody to know that she has no electricity. She's working with a phone, managing 3 different things in 100-degree temperature in Texas. So Rose, thank you so much. It's really amazing what you're doing as a moderator and with no electricity and in the current situation. So thank you.
No problem. No, I'm trying to do the best I can to make it seem like I'm not holding my cell phone up to the window to get service. I hope you can hear me again. Can you hear me okay again? All right. No, but what I was trying to say is that I think it's also important to know when not to do a bone biopsy, not only location, but also based on what you were saying as well, when, someone has been on antibiotics long term and things like that. At what point do you say just do empiric antibiotics? We don't need to do the bone biopsy.
Definitely. So, like say one thing we talked about earlier was the location. If the area of interest in a location was not amenable to a biopsy, then that's definitely one of the things. And the foot is not a loud location, mainly, the distal phalanx, maybe some of the cuneiform, we have a lot of like neurovascular structure dorsally, you may want to avoid that. But location play a big part. Another thing is definitely vascular status. If they come in and they have, very poor vascular status, you can tell it's a cyanotic toe, they have no palpable pulse, they got non-invasive test done already and come back bad, they're on a way to get a revascular. Definitely, I would probably go with more empiric because you don't want to cause an injury to someone who is a vasculopath and subject them to a wound that could become necrotic down the line and that may not heal. So the vascular status play a big role as well. The one thing that doesn't hold me back from doing biopsy anymore is the duration of antibiotic. Like I was saying in the lecture, like the percentage decrease in the bacterial culture yield is actually not that significant. So even they have a dose or 2 doses or even like a week, I still do it, especially most of these patients who present with bone infection, mostly go to the hospital, get admitted. So the podiatry or ortho or whoever the hospitalist consult, usually we see them in 24 hours or 48 after they get admitted to the hospital. So how much antibiotic can they get in that time? Like dose, maybe 2 days. So, and what we see was that it's about 1 to 2% decrease in bacterial yield. So it shouldn't deter you from doing the biopsy or hold the antibiotic for like 3 days or 4 days, like what most recommendations are, which is based on anecdotal. There's no clinical study or paper saying that you have to hold it for 3-4 days or a week to have back to 100% bacterial yield. There's no study that say that. It's all just personal preference from clinician to clinician. So, but to go back to yours, like not during biopsy, definitely the two biggest thing is the vascular status and location. And if I look at it and it's not a salvageable limb, then definitely don't bother doing a biopsy.
Right.
If you're going to amputate it anyway, don't waste the resource, the time, and
No, it's great, because I'll tell you one thing that we run into quite frequently. The patient has poor vascular status. They're not, they're non-VAS candidate. And then there's nothing that we can do amputation wise. So the ID team will request that we go ahead and do a bone biopsy so they can try long-term antibiotics. But you have to be careful that you don't get forced into that, because you know that the patient doesn't have good circulation. They think just because it's a small incision that that's not a problem. Just a small stab incision. If the patient has a vascular issue, don't let yourself be pushed into that. We've had plenty of situations. I've seen it before where I've come in and one of my colleagues felt pressure to do it, and now you have gangrenous toes developing. So just make sure you're understanding that the vascular status is paramount.
I agree, and the thing is, most of these patients are actually have high comorbidity. They're not just patient with poor vascular, the diabetic, the hypertension, they have chronic kidney disease, on dialysis maybe. So they are at immunosuppressed state most of the time, where during that small incision, that small opening you have could be the one thing that caused them to get an amputation. And as most literature show, the most common pathogen for osteomyelitis is the staph organism. So empirically, you can just come from staph and strep and mucin gram-negative, and you should be good. Pseudomonas infection is not as often as we thought it would be. So empirically, recommending biopsy for those patients who are high risk for worsening after like a small opening wound.
Rose, can I ask you a question? As a non-podiatrist, this comes up all the time and sometimes can be very frustrating for us related to this. A lot of times, ID comes and they ask for an MRI and there is like bone exposure. And when I remember even from medical school, they told us if you see bone or if you can touch bone, is osteo until proven otherwise. Is that still the case? Because we have a lot of folks that are non-podiatrists on the
Sure.
Can you comment on that? Or one of your
No, absolutely. If bone is exposed and you're looking at it, it's
No, I think we're losing her.
yeah, not necessarily only a biopsy at that point, but absolutely, if the bone is exposed, it's infected.
Yeah, and I agree with her. Like every time I see bone, the question is, how does it present to you? Is it exposed when the patient presents it, or is the bone exposed after you debride a wound or uncover something, an eschar?
Yes.
And I agree with this. If you see an open bone present to you with a patient with a wound, definitely assume it's infected. And the bone is right there. You might as well take a biopsy. Why do an MRI? Gold standard for osteomyelitis diagnosis is a bone culture. So if you see exposed bone, it's nothing easier than taking a rondura and just take a piece of bone out, and you can know if it's still viable or not. MRI is very effective, yes, but there's also a false positive. It's fairly low. It's less than 5%, I believe, a false positive MRI. But the thing is that the timing and the resource to get them into MRI is most of the time it may take days for them to get MRI. You see bone, just take the piece of bone right there and then just send it and forego the MRI, which tells you more information.
And the MRI should really be used to potentially surgically plan and tell you the extent of where the infection is if you're not sure about that, if you're looking at adjacent metatarsals and whatnot. So I completely agree. I think this was such a great topic of discussion. This was really well put together.
Oh, great. No, the MRI, absolutely. I think if it's coming from ID, doesn't need to happen. If it's coming from podiatry, we probably need it for surgical planning. So go ahead for it. Yes. So thanks a lot, David. That's great.